Hi, my name is Erica. I'm a medical resident from Melbourne in Australia. So firstly, thank you for your great talks. So my question is, in the last year, there's been a few articles on being overweight or obese and being fit and healthy. And that created a bit of controversy. And even some health professionals, they advocate for health or healthy at every size, so regardless of weight. And there are some also like non-diet dietitians, which I just learned recently. I've never heard of that before. And one of the arguments is that being a little bit overweight or on the overweight side can be protective, particularly in the elderly. My question is if you have anyone could comment on that, is being healthy at any size, regardless of weight, a thing, and can carry some extra pounds, particularly in the elderly, can be protective at all.
I'll comment on that and then can pass it around. But there actually was a study, it was a couple weeks ago, and it had 90 in the title, where the 90 plus, there was a cohort study of 90-year-olds pretty well, and the ones that were a little bit larger, I think 10 to 15% heavier than ideal body weights, had better longevity. But that's a far different group than what we see clinically. So there's fit but unhealthy, which I see a lot dealing with military and athletes. So people can be uber fit and wreck themselves, and that was my story about 7 years ago before I decided to look at my diet. I had A1C of 6.3, and doing all these crazy endurance races, looked the same size as I did now, but woke up at 2 a.m. needing more cereal. My body couldn't metabolize fat at all. So metabolic health, it like everything, it all depends. Metabolic health matters, but yes, body weight matters too, because if you look at the curves of mortality, cardiovascular disease, so it does travel with, it is important. I don't think we can tell people that it's fine that you're 100 pounds overweight, even if maybe some of your metabolic, because there's probably markers we just don't know. I think everyone needs to do the best they can, and every single person we see clinically can get healthier. And the fit people are the ones we have to get to chill out, because they're out there hammering their bodies every day, and we know there's higher rates of AFib, possibly even cardiovascular disease, and the people out there like, type A's out hammering workouts, to failure every day. Don't do that. It's bad advice. But anyone else want to tackle that one?
Okay, why don't we take a question from over on this side?
Okay, by the way, Mark, I was one of those chronic exercisers that led to AFib. This question is for Megan. Question is, differences in fasting ability or ease or whatever between men and women. I know between my wife and I can, between May and January, I did 5-day fasts every 14 days and had no issues. And my wife she'll do a 7-day fast once a year, but has a much more difficult time doing it. Is there any comments?
Okay, we'll swap. Thank you. In our clinic, we really push consistency. So not just periodically throwing in a fast here or there. We find when people, once or twice a year try to do more of an extreme fast, regardless of whether they're men or women, they both tend to struggle. So we see just as many men struggle with longer fasts as we do women. Jason and I anticipated that we would have a lot more difficulty with women, especially women going through menopause or postmenopausal women. But with consistency, I will say that their inductory period into fasting is a little bit more rough than men. We got more hormones than you guys that screw us up. So with them, the first 4 weeks tends to be a little bit more challenging. But after that, we see the same amount of body fat reduction. We find these women are fasting with just as much ease as men. But it is a bit of a more rocky induction into fasting for women.
Okay, thank you.
Yeah.
Hi, everyone. I introduced myself yesterday as Nadia Pataguana. I'm one of Megan's colleagues, and she was actually my mentor. And so I'm up here today, on behalf of my patients and Megan's patients, just to thank her for her talk, because I think yesterday there was a lot of, I would say even within our patients, there's a lot of confusion why somebody as renowned as the doctor that went up yesterday that spoke about fasting created a lot of confusion. And I think Megan today did two really great things. One, she clarified a couple of important issues. And two, hopefully she has opened up some curiosity for people to clearly look into fasting properly, not to just fast and think that it's not a useful tool. It is a useful tool, but it's a powerful tool. So I think Megan did a great job. On a personal note, I think Megan knows I have a lot to thank her for. I've been in the low-carb world professionally for quite a while. I only learned fasting from her, and although I was very successful with low-carb, high-fat, for me personally through my health journey, my husband struggled a lot. And so when I started working with Megan and Dr. Fung, my husband thought, well, this looks like what I need to do. And we were very lucky, of course, because we had Megan and Dr. Fung to supervise him. And he did, his very first fast was a 12-day fast, properly supervised. And that was the thing that broke through his plateau. My husband today, so it's been 2 years of intermittent fast, extended fast, and a good keto diet today. And he, today at 43, I wish I could show you guys some pictures, but he weighs less than he did when he was in high school. He is off all of his medication. When I met him, he was actually a friend of a friend, and I tried to get this guy when he was 30 to get off of hypertensive medication, and his doctor wanted to put him on a statin. Luckily, we were in South Africa, and the doctor said, don't go on a statin, try and try and try, and it was thanks to Megan and Dr. Fung that he is today as healthy as he is. And I always use him as an example to my patients, because if done properly, this is a very good and powerful tool. And even I couldn't help him with just keto. So I hope that gets some of you thinking about it from a safe, yes, but as an option as well. Thank you.
Thanks, Nadia. Nadia is our resident baby maker. It's true, but you got to make sure these fasts are medically supervised. That's the most important thing. You don't want to be fasting all willy-nilly. So make sure you're getting your labs routinely. Make sure you're following up. And if you feel unwell for any reason, that you just stop the fast. You can always try again. That's the biggest take-home message. You can always try again. You shouldn't ever suffer.
Can I ask, I'd like to ask Dr. Eades if you could comment, because you've been doing low carb with your patients for a long time now. Is fasting something you ever used as a tool, or if you were to go back into clinical practice, do you think that that's something that would have a role in your practice?
I don't know. We didn't use it in our practice because it wasn't really around. Nobody had thought about it. It never occurred to me to tell people just to quit eating. But we, my wife and I have done intermittent fasting off and on for, I don't know, 5 or 6 or 7 years. I wrote a blog post about it way back when, and I think that kind of kicked off a lot of interest in it. That was probably maybe 10 years ago now. But the way that we've come out, the way that we use it, and it's effective for us, is that we start at 6 o'clock at night, so that you never go a whole day without eating, because we try to do alternate day, and it's kind of rough on the alternate day, especially if you've got kind of a busy social schedule, and then that night comes in and you're supposed to go to a dinner, and then you have to switch things around. So by doing it at 6 o'clock until 6 o'clock the next night is pretty nice, because that gives you a lot of flexibility, and yet you still go 24 hours without food. And I would encourage people, everybody else has talked about this, but make sure that you take plenty of sodium and all the other electrolytes. That's the one thing that's really important and can get you through it.
Thanks. We'll take a question over here.
Yes, also for Megan, a comment and a question. First of all, thank you for a balanced perspective on fasting based on real-world outcomes. Appreciate that. I've done, over the past year and a half, my own personal research on prolonged fasting and intermittent fasting. I won't tell you my first prolonged fast of 14 days, how I did it, because I'm pretty sure I violated all the rules that you presented. But anyway, I got through it. But my question to you is, I fell into a routine. I really became to like the 24-hour fast, eating once a day. And I was doing that originally just for weight loss. But now it's become my lifestyle, and I don't want to give it up. I'm not trying to lose weight anymore, but I love it, and I can't get away from it. I was wondering if any of your patients ever kind of get into a mode where they really like it and want to maintain as part of the lifestyle?
Absolutely. So doing 24 hours once a day is popularly known as OMAD, or 1 meal a day on social media. That's usually what people end up doing in maintenance mode. You know, their appetite is reduced, their insulin levels, their ghrelin, they have more control over their appetite. They're just not as hungry anymore. So we often see people, when they sort of graduate and their metabolic syndromes reverse, go into a 1 meal a day pattern. My husband and I actually do that now, and that's sort of been my maintenance mode for the last several years. We usually eat lunch Monday through Friday. I'm old now, I don't like going out on Friday nights. And then Saturday and Sunday, we'll usually eat twice a day on Saturday and Sunday, just to mix it up and socially. But it's just, fasting has given me time back, and I think this is what a lot of people appreciate with fasting. Eating well requires a lot of preparation and time, and some of us just don't have that ability to do so. My life's crazy. I'm in the clinic like 100 hours a week. You know, we have groceries delivered to us because we don't have time to go grocery shopping. So fasting has given me time back. When I was first diagnosed with metabolic syndrome, I was just trying to radically change my diet. And the amount of time and effort that went into having to have a healthy diet consistently, I didn't have time for that. So I would actually got anxiety about my days, you know, going by so quickly, wishing there was 4 extra hours in the day. I became behind in life and in work. And fasting, I had time to catch up on all of these things. My priorities sort of shifted, and I just found that very liberating. So a lot of our patients do. And they find it very easy to always fit in eating one very healthy meal a day. Doing meal prep for one very healthy meal is not very time consuming. So they can maintain that in the long term. And I find that works very well for our patients who have now graduated to maintenance mode. It certainly worked well in my life.
That's exactly how it worked for me. It's easy, and it frees up time, and it's, I don't know, I'm not going to give it up. So anyway, thank you for the answer.
Thank you.
I'm an internist, and I see a lot of patients on chemotherapy for cancer. Question for Megan. Do you incorporate fasting for cancer patients on chemotherapy? And second question is, do you get pushbacks from oncologists?
So, thank you. So in Toronto, fasting, the idea of fasting and ketogenic diets is becoming more accepted by the oncology population. So for reasons, Jason and I, you know, we didn't engage with those patients, but we had their oncologists, you know, reach out to us and say, hey, can we just try this? We don't have to do anything radical with them, but let's see what happens. So it was actually pushed from local oncologists that we actually started doing some experimentation in our clinic with cancer patients. So while patients are actively undergoing chemotherapy or radiation, we do not do any extended fasts with them. We do not do really any fasts. We focus on time-restricted eating. So they'll eat, most of them will eat about 2 meals a day. We really eliminate snacking, and we really encourage a ketogenic diet with these patients. But between rounds of chemotherapy, between rounds of radiation, we do fast with them. So with these patients, depending on the patient, of course, we try to focus more on water, salt, magnesium fasts, ranging anywhere from about 24 hours to about 72 hours. So there's so much about autophagy that we just don't know. And Jason and I, oh my gosh, every day get 100 emails about autophagy, but the research just isn't there. So we don't know if more prolonged periods of fasting might be very counterproductive. So the max that we usually will fast the right cancer patient for is about 3 days, and that's a protocol that we've developed with local oncologists in the city of Toronto. So never during chemotherapy, but around chemotherapy. During chemotherapy, we focus on time-restricted eating and a ketogenic diet.
Because fasting decreases the adverse effects of chemotherapy, especially if they do it before.
Yes.
But what about those patients who have the cachexia of malignancy, those who are wasted from it? Do you still do a little bit of fasting?
We still do some fasting. For them, we work more on their diet, really increasing the fats, like substantially fatty diets. Like I have one patient who fit that profile. He would eat 6 avocados a day. He would eat 3 meals within a 16-hour period. He would have 5 tablespoons of oil per per meal in addition to those 2 avocados per meal. So the fat load was quite sufficient, and he never lost weight throughout any of his fasts. And he was someone who we typically fasted for about 3 days in between treatments. So during his chemotherapy, we really focused on an exceptionally high-fat ketogenic diet.
Hi. Nick, sometimes I think the line that's drawn between natural and unnatural comes down to thinking. So parts of our body are accepted as natural, and things we do intuitively are natural, but whenever we have to think about something or use our brains in that cognitive way, it gets categorized as not natural. Sometimes I get harassed by vegans on Twitter who say, you don't have claws or sharp teeth, so how can you say that humans are carnivorous? And I say, well, what about thinking? If we get our animals from thinking, does that not count? And I'm just wondering if you have any thoughts on thinking.
Did I not go around in circles enough? And you want us to think about thinking? I mean, when somebody says that thinking and our ability of cognition is not natural, then their only alternative really is supernatural, which people postulate, but that's fine. And if the vegans believe that we are all our own gods, then that's perfectly acceptable. But if they don't, then I think there's a fallacy there, and they're begging the question that just because we're using some sort of ability that we've evolved to use somehow makes it less natural than if we happen to be using claws or teeth. And surely the tales told at conferences like these about this weird ice age species that suddenly cracked onto the clever hack of building a huge brain to bring down animals that really we had no right to bring down. There is no way our scrawny apes should have been able to bring down the huge megafauna that we did, let alone make them go extinct. But we did. Was that unnatural? Well, is it any more unnatural than a termite that builds a really good termite mound or a beaver that creates a dam? Maybe they are unnatural as well, but then we've got a strange definition of nature. So yeah, I appreciate that vegans are shouting at you a lot, but I don't think that sending them a first-year logic primer would help that.
So, Megan, you somewhat contraindicated long-term fasting for people who have like less than 10% body fat, and some of them may have diseases like fatty liver, even though they are lean. I'm one of them, and so I have 2 questions. What concerns do you have for long-term fasting for people who have less body fat? And the second question is there a fasting protocol that helps eliminate fat from the liver but not from arms?
Usually for a slender person, I mean, there's so many factors to take in consideration, so I can't just throw out random advice. But if someone is quite slender with fatty liver disease, we focus on a very, very high-fat ketogenic diet for these individuals to make sure that they're getting sufficient calories on their eating days. We usually will fast them for about 24 hours, but there's a lot of factors that go into that decision. The biggest issue with people in general with not very much lean mass is we don't want to run into any issues with refeeding syndrome. They don't have a whole lot of body fat to fuel on in the long term. We don't want to tank out their metabolic rates either. So while having a lower metabolic rate there's lots of research that supports that's good for longevity, you can't totally obliterate it. There are several professional athletes that I work with. One in particular was diagnosed with colitis. And so he is someone who would definitely benefit from doing longer fasts more periodically. And he's someone who says, if I never go back to my professional sport, that's okay. So do with me as you will. But you have to educate them about fasts. So we will fast him about once every 6 to 8 weeks for about 3 days. but it's definitely not on a weekly basis or on a routinely basis. So you have to be cautious with this. We don't want to run into refeeding syndrome. So far, we're 0 for 5,000, and we don't want to put you in harm's way either. So usually with more slender people, we cap them at about 24 hours, intermittent fast. That seems to work very well, maintain their lean mass, and do resting metabolic rate. I am aware, and I think Steve Finney made this very clear yesterday, we need more research. Well, in Toronto, we're collecting a ton of data. We're 5 years young, so I hope within the next couple of years we'll have sufficient data to give Steve Finney that research on lean mass. But just be cautious and make sure that you're fasting, you're being medically supervised. If you don't feel well, signs of getting too cold when you're very slender, you don't want your metabolic rate to drop too low. So make sure you fast with some medical supervision.
Thank you.
Good. Over here.
I have a question for Megan. You talked today about the basal metabolism rate after 2 days and 3 days, and yesterday Finney mentioned like over prolonged fasting that the basal metabolism rate goes down, like water fasting 7 days, 14 days. Do you have any experience with that? What is your observations with that?
So most of the new research that's out on fasting focuses on alternate daily fasting.
Right, I know. I read that. Yeah, right.
In clinic, we do, in our clinic, we do assess basal metabolic rates.
Mm-hmm.
And we do fast people for prolonged periods of time quite frequently. So it is something that we are tracking. Again, we are 5 years young, and hopefully within the next couple of years we can produce some data on this. Mm-hmm. But we're not seeing adverse effects with up to 14 days of fasting with our patient population in terms of resting metabolic rate. Keep in mind, though, people who are quite obese have very high metabolic rates because their body's actively trying to lose fat. So people are going to see a reduction in body resting metabolic rate or basal metabolic rate as they lose weight, and that's in their favor. As Eric Westman pointed out yesterday during the Q&As with Dr. Finney, that you don't want to have a crazy high metabolic rate. So we have these quite obese people, their metabolic rate's very high because it's fighting their obesity. So you are going to see that come down. So sometimes having your basal metabolic rate come down actually in favor of your longevity rather than counterproductive. Hopefully that's clarified your answer, Bob.
That is, and I'd be curious to see that research, when it gets produced.
We're working on it.
Right. The thing that I noticed yesterday when Dr. Finney was talking was he was talking about these people that do the greatest loser. Those people are not fasting. They were doing dietary calorie restriction, and that will mess up your metabolic rate if you do that over a period of time. And so you can really mess yourself up doing that. But it's not the same thing as fasting.
No, it's not.
Could you comment on that?
Fasting's intermittent. So the study I talked about today was published in September 2016. The results are identical to what we're seeing in clinic with alternate daily fasting. The study compared two groups. The alternate daily fasters were taking 2,500 calories a day on average on their eating days, and on their fasting days 0. And on the calorie restriction, they were taking about 2,000 calories a day. So roughly about 400 to 500 calories less than the alternate daily fasting group. We saw a much more substantial reduction. When you're fasting intermittent, you're confusing the body. And I think, so Bob is a patient of mine. Mm-hmm. And we talk a lot about this, going back and forth. So just like Dr. Finney said yesterday, you don't want to have a crazy high metabolic rate, but you don't want to have a low one when you're trying to lose fat mass. That's sort of counterproductive. And doing the alternate daily fasting sort of throws off your body. It tricks it a little bit. But when you're consistently day in and day out giving your body the same energy budget, your body will adapt to that budget. Just like if you had a reduction in your daily salary, you would be able to downsize your spending to adapt to that salary decrease. But when it's sort of all over the place, you sort of sit somewhere in the middle. So yes, we do see resting metabolic rate drop a little bit, but it's not too substantial because you're going back and forth. So that's the beauty of the alternate daily fasting. It confuses the body a little bit, and it keeps your metabolic rate running a little bit higher while you're trying to lose weight. Whereas caloric restriction, when it's the same day in and day out, the body adapts to that energy budget and will start slowing down your metabolic processes to adapt to that caloric intake.
Thank you, Megan. And I would like to make a comment. I've been a patient of Megan's for 10 months, and I've worked with a lot of different medical professionals over the years. And she said she works 100 hours in clinic every week, but the big thing that she does that helps people is she really cares about people, and she's very specific and individual with her advice. And she's one of the most caring individuals, but she's also got a lot of experience. And so I just want to thank you for all you do for us. Thank you.
Thanks, Bob.
I just have two short questions, hopefully short. I'm Bill Errico. I'm from a small town, a family medicine doc from a small town in central Washington state. First question's for Mark. First of all, thank you for your service. I'm a fellow Air Force as well, and my wife and I wouldn't have met without the Air Force. I was trained at Travis Air Force Base, family medicine residency, so fellow Air Force. So the question's really about trying to implement changes in hospitals, and our hospital's in a small town. Small hospitals are sometimes on the brink of bankruptcy. I think ours is pretty close every year to going under. And I saw one of your slides about some of the organizations that stand to lose a lot of money from changes, and I just wonder how much impact that makes when you're trying to implement low carb and healthier eating in the hospitals, because I just find that to be maybe a challenge since you had to make some compromises. What would you say to that?
Yeah, that's a great question. So financially, the low carb menu, so we have a low carb pathway in our hospital. So 10-gram carb per meal. It's a wash with the cost of that. You saw it was eggs and some salad, and they do meats and hamburger. It's not grass-fed. It's what I'm sure they get from Sodexo, which is the vendor. Legally, we did get out of this. Was to our favor. So hospitals make some money off of their vending of all of these soft drinks and sugar-sweetened drinks. So when we negotiated to go sugar-free of the beverages, we were relieved from being responsible for any financial loss that would occur. So I don't think there's other hospitals that have done this. Everyone's worried we're not going to, hospitals, philosophically, we're not there to make money off of Coke. I think, you empathetically share that with the group meetings, but we actually were waived. So if with this initiative our hospital loses $1,000 from less vending machine sales, it's okay. It's not going to be a problem or shut down this initiative. But they switch out the beverages to sugar-free beverages, so people still go buy the beverages. Right. Sure. And we're switching the vending machines to healthier option vending machines. So all that junk food's gone, and we're looking at a couple right now. They're gone. We're looking at a couple different vendors that have real healthier options. Maybe not keto or paleo, but certainly better than what you see in most vending machines.
Thank you. I was very inspired by your lecture just on that.
Just get involved and thank people, and bring them into conversations, and it's like moving a rock, right? Little by little, you just find your allies and get your leadership to buy in. Without your leadership, and it has to be bottom-up change. So you have to create a culture in your hospital that they take pride. A small hospital can really take pride. Like all the big hospitals, they're like there's big industries, right? So you get some little hospital and you just give them pride, and they want to do it.
Yeah. But just a really quick question to Megan. I'm very inspired by your work and just how hard you've worked and your compassion. And I just wanted a question. I wanted to tell you a situation that I've just had with a patient of mine, and then ask you a question about it in light of the chronic pain lecture we had. So I had the patients that we see with chronic pain are very difficult patients, because as physicians we're trained to be empathic, and when you're seeing these people day in and day out just crying and just so frustrated and just so at the bottom every day, it drains your energy. Your day is very difficult after that. And for the first time, after being exposed to such wonderful work that you've done, I've for the first time been able to offer her fasting as a choice with monitoring and close follow-ups. And for the very first time, she's reduced her oxycodone, and she's first started with 24-hour fast, but her and her husband, with his help, have gone to 72-hour fasts with going off diuretics and things like that, just with some supervision. And it's really the first time that she's really noticed a huge impact on the pain. And when she finally came back to me about 2 weeks ago, she had so much energy, and she brought energy into me, and I felt like injected with her energy and thrived the rest of the day. So it was amazing. So I owe it all to you and Dr. Fung's work. In light of that, though, in your practice, you didn't mention a lot of chronic pain patients. I know a lot of your diabetics have chronic pain, but are there some people that just come to you simply for chronic pain management?
Yes, we have a big pain specialist doctor in the city of Toronto. I think he sends us about 300 referrals a week. So a lot of patients with fibromyalgia. I'll tell you, they're some of our most determined and our most successful patients. And I'd say pretty much almost all of our patients across the board experience some sort of chronic pain. So I'm almost desensitized to talking about it because everyone I work with has it. But they're some of the most successful patients. They don't want to live life in misery, so they'll do it. And I found with them the biggest issue is stress eating, comfort foods, carbohydrates. So giving them the option just to refrain from eating, it's empowering to them because then they still get results, and then as they get results, you build on small successes, and so they get the pain reduction, they get the weight loss, they get all these great things through the fasting, which just makes them want to eat better and fight through that emotional, that stress eating that is really sort of just aggravates their pain so much more. So we have a tremendous amount of success with our patients and pain management, especially fibromyalgia. We have a lot of fibromyalgia patients as well.
And her specifically was polymyalgia rheumatica, which tragically the only treatment is prednisone, which we all know what happens when we take prednisone. So it's to see her say, I'm going down on my prednisone dose, and that's pretty inspiring.
Yeah, we have a lot of patients on prednisone too, and both Jason and I thought at first, damn, we just want to help everybody. And I've been amazed at how well people respond, even when they're on very high doses of prednisone. So they're always so discouraged, and I say, you don't need to be. And now I have the confidence to say that to them and know that we can help them. So it's nice to see them be able to reduce that as well over time.
Thank you so much.
Thank you.
Okay, so it's close to 12:15. I think we should take one more question, and then if any of the speakers have time, maybe some of the other questions will be taken off after the general session.
Sure. My name is Tom, and my mother, Mary, and I live in Littleton. And I just want to say thank you to Dr. Gerber and Aaron Kay. They are our family physicians. They are very caring, and they listen, and if you need to travel 1,000 miles to see them, come skiing to Denver and go and see them. And it's a fantastic story that we have because about 4 years ago she started this diet with Dr. Gerber and lost I thought it was crazy at first. I thought it was nuts, 70% fat. I was like, what? And at the end of the year, she had lost 35 pounds, and now she looks like 20 years younger and feels 20 years younger than she is. And our lives are just improving so much. And I started it 6 months to a year after she did. And the last 3 years in school have been the best years I've ever had in school. I'm able to go to class. I don't miss classes. My grades are up. And I'm doing really much better. And so thank you for this. And so this is unsolicited, and I'm probably going to get scolded for this later, but you should look, I think it's page 87, Mary's story. That's my mom's stories in Dr. Gerber's book, so she's got a great story, page 80-something. Anyway, my question, really quick, for people that do 12-hour fast or sun up to sundown for a few weeks out of the year, some people believe in drinking water during that fast, and other people believe in nothing, not even water, drinking a lot before and then after. So is there any medical opinion on that?
I guess I'll combat this one. So being in Toronto, over 30% of our patient population actually participates in Ramadan every year. So they do a dry fast from sunrise to sunset. And I think Jason and I had one of the most we are idiot moments was never reflecting on the success of these patients throughout Ramadan. We always had to adjust their, or not myself, but Jason would always have to adjust their medications down. They would do well. Well, as long as they didn't pig out when the sun set, I should say, they did well. In our clinic, though, we do not recommend dry fasting. Anyone is susceptible to refeeding syndrome. You don't have to be malnourished to develop refeeding syndrome. So electrolytes are really critical to our protocols in the intensive dietary management program. So do a lot of people fast successfully during Ramadan from that fast? Yes, they do. Are there complications? Every year there are complications as well from it. So in our program, we really focus on the hydration. We really want to protect our patients as much as possible, and refeeding syndrome is not a pleasant thing. So we do water, definitely water, salt, magnesium, bone broth, really making sure they're getting in the electrolytes.
Thanks. Just to follow up on that, do you recommend more than just water, or like electrolyte drink, or just water during the day, or?
Yeah, it depends on the intention of your fast. Nowadays, we have people fasting for all different kinds of reasons. And combating metabolic syndrome, we say like water and salt fasting is the fasting of the Olympians, right? But in patients treating metabolic syndrome, we're perfectly comfortable if they consume coffee and tea and broth during the fast. We really encourage black coffee and black tea. A lot of people nowadays, there's more information out there about autophagy or trying to have very clean fasts, since we don't fully understand the effects of things like coffee and tea on autophagy. So for those patients, as long as they're supplementing with salt and magnesium, we don't see too many issues, not in clinic anyways, but we are monitoring them medically. We're like the vampire club in our clinic in Toronto. We always want their blood. So we're keeping a close eye on all of their levels.
Thank you.
Okay, I'd like to thank all the speakers, and if you give them all a warm round of applause.